What we started was, a few years ago we started in chemistry designing new copper complexes for imaging hypoxia, so areas of low oxygenation within solid tumours. And the compounds are labelled with radioactive copper, so it's a metal, it's a radiometal tracer. And we've got some quite successful chemistry going, and we managed to make some new compounds. And when we looked at them in isolated cell culture, they were looking really promising. And then we needed really to move to somewhere like the Gray Institute so that we were able to do the preclinical imaging in animal models. But historically, people have used PET as a static method. So you take a patient, you inject them with a radio tracer, you leave them in a lead-lined room for a couple of hours, and then you image. And what you get is a picture, essentially, which needs to be interpreted. And what we've found, and what myself and Rehan Ali and Kat Kelly were all talking about at yesterday's PET session, was how if you do dynamic imaging, if you inject the patient whilst they're in the scanner and acquire data with time, it's possible to draw out some quite interesting biological conclusions which are hidden if you just take a static image. And so what Rehan Ali was able to do, working with me and Mike Brady, was able to really tease out some biological interesting additions to the mechanism of action, which might help us interpret the PET scans more interestingly, might help us design new tracers. And the insights from that mathematical modelling were really not apparent and would have been quite difficult to come across unless you were actively looking for them. And now we know that they're potentially there, we can go looking for them, okay, and potentially do some more interesting things with the PET images that result. Historically, the accepted mode of action of the copper complexes was that they go from outside the cell to inside the cell. Once inside the cell, they get reduced by, for example, NADH, NADPH, and then in the presence of any oxygen, they get immediately reoxidized and they can leave the cell, re-enter the cell, carry on as before. But if there's not enough oxygen to do that reoxidation, they fall apart and leave the copper inside the cell, and free copper cations will immediately get bound up with any sort of passing protein and held inside the cell, and that was the accepted mechanism. But what we found is that the mathematical model doesn't fit that data. It does fit that data, but it doesn't fit it as well as it might do. And if we add a box that allows the copper to leave the cell, if we add that idea that once it's not permanently fixed, but it gets out, actually the quality of data fit to the mathematical model is very much better. And of course, if you're looking at a PET image and you've got a bright spot in the tumour, you need to be able to say that bright spot is a product of the rate at which stuff is delivered, but also the rate at which stuff might be leaving. And if you're not taking into account the fact that the tracer might leave, then potentially you're misinterpreting the image and you're falsely assigning the patient to a category of hypoxia. And in being able to tease that out using mathematics, which is quite difficult to tease out experimentally, but in principle, one, maybe two scans without much inconvenience to the patient and a more detailed mathematical analysis of time-dependent information, you potentially not falsely assign patients to a category. And really, you're using PET images to make clinical decisions. And so that's, it's important that those are properly assigned. Or assigning them to the right course of treatment. There's a lot of work going on out there to try and remove areas of hypoxia or target radiotherapy to areas of hypoxia. There's a lot of work going on to try and alleviate the consequences of hypoxia, which is basically that treatment fails. Hypoxic tumours are resistant to treatment, and there's a lot of work going on to address that. But obviously, that's potentially expensive, potentially more invasive, potentially more an inconvenience, the patient spending more time in hospital, and you want to correctly assign patients to that course of treatment, and you need to be able to detect, quantify, delineate areas of hypoxia so that the surgeons are treating the right disease or the right aspect of the disease.